I think in the respiratory field there are really good national examples as well, where industry and academia and others have come together to try and focus on specific disease areas, and some of those have been promoted by some of the charities here and the organisations. Really good examples are the UBioPed project, for example, which was funded by the IMI.
Can you explain what that is?
Yeah, it's funded by the 7th framework of the European funding. That allowed sort of multiple clinicians, academic organisations across Europe, but also working with industry and pharma to look at whether or not we can sort of fingerprint patients with asthma. So can we define the disease and the biology, and as a result of that, can we create a right patient, right treatment format? So it's really a form of personalised medicine as well. So nationally, that's a good example. I think probably the best example is the NIHR, with the advent of the NIHR, which we're all signed up to, which is part of the NHS, and a big remit of that is really to try and improve the focus for commercial input. We know that Pfizer and AstraZeneca and others have sort of left the UK in the last 10 years or so, but really that sort of void in R&D needs to be replaced as well. So, you know, the UK, I believe, is a fantastic place to do research. If you only have a look back from sort of Nye Bevan's era and 60 plus years, every decade we've had some fantastic innovations, from IVF babies and Charnley's hip and the Glasgow coma scale, for example. And actually, if you look back, the proudest thing is that we've had 34 Nobel Prize winners associated with the NHS. Now that's something to be proud of. I think as how are patients going to improve? Well, I think that's going to be improved in lots of really ways, especially in respiratory care, because I think the technology will allow us for the right patient to have the right treatment at the right time. It'll allow us improved diagnostics with point-of-care devices, allow us to understand how we interact with infections, because infections are the commonest causes of exacerbations in asthma and COPD, and the greatest burden on respiratory care in the NHS. So I think in terms of diagnosis, but also there's an opportunity for us to intervene with that. So patients will you can use apps, for example, and mobile technology and other things to try and get patients more activated, to make better lifestyle choices. So I think for patients it'll be around education, better medicines and improved diagnostics.
Okay, and you think that we need to partner to do this? The NHS can't do some of these things on its own, it needs partnership, doesn't it?
I think just looking back at the NHS, there is a good history that we can do it. Okay. But the challenges that we face now with the shortfall in funding are about delivering care, which means that the R&D budgets are restricted. So you really have to mobilise private sector funding in order to address this common goal. So I think it is necessary.
I mean, I don't think we do hear much about good public-private partnership.
Is that just in The Guardian, or is that...
I think well, I explained earlier there is an issue about that, but I think more generally, I think because the term is so broad, it's so loose and baggy, that everything from crude outsourcing through to collaboration is brought in under this umbrella, and therefore the shocking failures, and let's be honest, there have been shocking failures in the health space and more broadly across the public sector, taint the concept. So yes, I am prepared to believe there are good examples, as Anup says, but we don't hear much about them, and I wonder if that's because people are. It's a relationship that dare not speak its name anymore because of the bad image it's got.
And there are real examples which have turned skeptical researchers into really believing patients can have a voice, and especially around the public-private enterprise. I'll give an example. There's a study of a drug in prostate cancer a couple of years ago, and after the drug there was a period of follow-up, and the patient information sheet in the follow-up said watchful waiting. And patients did not want to sign up for this study because they were waiting for something to happen. Patients don't want to know. As soon as they put the information sheet to a patient to say, how can we recruitment, the patient identified that actually if you just say active monitoring, that'll get you more in. So simple change like that looked at the recruitment figures just enormously the other way. So this is a sort of real life examples about how patients can really benefit in terms of commercial research trial, but also not only to address the areas that we need to do, but when you actually do the research, make sure that your patient-facing material, your communications are all lined up in the same way. And Asthma UK, to their credit, are particularly good at this, especially in terms of the social media campaigns, for example, when there's a large trial in asthma, for example, everybody gets to know about it because through the Twitter feed. So I think that connectivity and patient contact can really improve. The area where we don't have a real issue is around the governance, around clinical delivery. And this is why we get instances like Southern Health and North Staffs as well, where patients really around the edges are crying out that there's a change that needs to happen in the health system. But there's nothing in the NHS constitution that requires a patient to be on the board or within the clinical delivery teams. And if we change that simply, I think we would really transform some areas of clinical practice.